Dr. William Brieger is a certified health education specialist and has a doctorate in public health and international health from the Johns Hopkins University and a master's in public health from the University of North Carolina in Chapel Hill. He has worked and done research in Nigeria for over 26 years, and he's here to talk to us today about community change and models for community change with respect to food security. So, Dr. Brieger, I'll turn it over to you.
Thank you. It's good to be with you all. The social cultural approach, fortunately, when I was in my MPH program, this was something that was stressed very much, that you cannot do health education unless you understand the culture of the people you're working with. And in that time, we were working with different groups in North Carolina, but then I obviously moved on and worked in Nigeria and other African countries for a while, and so have learned a lot about understanding people from their own cultural perspective and bringing that back to the U.S. and recognizing that now the U.S. has many people from many different countries, which we always have, but in terms of program planning and food needs, we need to be aware of the cultural perspective of the different communities that we're working with. In terms of general change theory, one of the approaches or models that has been helpful for me to understand planned change, and that's what I think all of us are doing, trying to plan improvements in communities and improve the food and nutrition of our communities. Three of the approaches. One is the power coercive. This is change by force. It may be legal, changing laws, physical. It may even be nonviolent types of change, but the idea is that we need to really push people to get them to change. There's inertia, there's reluctance. The empirical rational approach is what we often see in many health and social programs. We have our experts who have been trained in the universities with master's and doctorate degrees in various kinds of professions, and so they have done a lot of research on what things work well, developed innovations, and have the approach that if you explain to people and tell them what is good for them, they will take action because they are so motivated by reason. And then the third approach is normative re-education, and we look at the issue of community norms and values. And the idea is that the community itself is guided to examine its own norms, examine its situation, examine its beliefs and perceptions, and comes to a realization of what needs to change on their own through self-examination, dialogue with the change agents like ourselves, and then they re-educate themselves, as it were, to take up new programs and new behaviors. A simplistic way of looking at it from the community point of view is that social change in the communities can be divided into two approaches. One can talk about the functionalist view, that community as a system may no longer be functioning. And in our case, the lack of function may be in its ability to provide nutritious and appropriate food in the amounts that people need. This may be due to internal problems, changes in neighborhoods, lack of access to food sources, external problems such as changes in zoning laws. But these changes that occur affecting the system encourage people to re-examine the situation and come up with solutions to reform and change. The conflict point of view, which again is reminiscent of what we just talked about in terms of the three approaches, the power coercive view, the change occurs when one group has more power than the other, gains ascendancy over other groups, and encourages or actually pressures people to do what they want them to do. Social norms would change as a result of being under the pressure to conform to certain laws, to certain regulations. In a very practical point of view, we found that Rothman helps us come up with 4 specific community change models to categorize the different ways we go about planning community change. Social policy planning is very much like the empirical rational approach. where you have many agencies that plan everything from nutrition programs, immunization programs, even city and regional planning in terms of where do we locate schools, where do we locate walking space. This kind of planning requires acceptance on the part of the community for the programs that the experts have developed. So again, using that people are rational, and when they see the good things that have been provided, they will want to use them. Social mobilization is a common term. What happens is, of course, again, the agencies have come up with programs, they have campaigns, they try to get people to turn up, whether it's attending maternal and child health clinics, whether it's getting your child immunized. The community participates to an extent, but not really as much in the planning, because the agency has taken that initiative. Social action could be seen as the conflict point of view, or even the power coercive approach, in the sense that there are imbalances. Our communities may be disenfranchised. They may not have access to food resources. They may not have good schools where children can learn about nutrition and taking care of their health. And so what would happen would be that community groups could organize and go protest, hopefully non-violently, but protest with the city council, with other authorities, with big business and corporations to try to bring change, bring more resources into their area. And finally, we have locality development that looks internally. The community examines its situation, its beliefs, its resources, its needs, and comes up with solutions using these local resources. So the community is pretty much in control of its own change. Now, no one model fits every situation, and sometimes there may be one or more operating at the same time. And again, we could plan different approaches. We may want to build on the resources the community has in terms of using grandparents, in terms of child care education, but also recognizing that the community may lack access to food in terms of being a food desert, and therefore we may want to involve some social action or advocacy work at the same time. A simple way of looking at the differences between these four models or approaches to community change is asking the question, where does the leadership come for deciding what needs to change and how change is going to be done, and where are the resources coming from that will make that happen? And so basically these could be either internal or external. If we are doing locality development, that means the ideas have come from the community, what they want to do to change, and they're using pretty much their own resources. If we have a situation where the leadership, again, comes from the community, they recognize their needs, but they lack the resources, then they could engage in social action to bring in external resources the community needs. Social mobilization, again, is pretty much agency determined, whether it's the health department, the education department, whatever, agriculture department, whatever it happens to be, comes up with ideas, and then they want the community to contribute their own resources to solving the problem, or at least in part. And finally, the social policy planning is pretty much external expert agencies are designing programs for the community using the external resources, whether it's government agency resources, corporate social responsibility resources, and then expecting that people will accept these gifts that have been given. Ideally, though, we do want to see the community increase its capacity to solve its own problems. And so if we're engaged in locality development, or we're engaged in social action, trying to get the community actively making decisions about how to use its own resources or how to access external resources, community groups, and again, this could be, we'll talk about coalitions, it could be community leadership from various social organizations coming together, but the community would look at its needs, its values, bring people together to make plans, improve its capacity to solve problems, and the community, you would see development outcomes that the community would have better, whether it's physical infrastructure, social infrastructure, to in the future continue to solve its problems. Now again, the community as a whole is made up of social networks, social units, and these are the active participants in this development process. And then of course these organizations are made up of individual people in the community, the individual citizens or residents. And so as the community is coming together to identify its problems and solve them and developing its own capacity, the organizational capacity of these local community-based organizations is improving, and members themselves are also increasing in their own skills and their own sense of ability, self-confidence to improve their lives, and so individual health will improve also. So this whole process of getting a community activated also improves the health of the individual members. And just some of the things that we're looking for, these different elements of a high capacity community. We can see that that includes communities where citizens actively participate in making decisions. There is strong leadership from the people. Skills are developed to, whether it's a question of skills in terms of determining good diet, preparing food properly, knowing how to order food if you're a local shopkeeper, bringing in the resources, as we said, strengthening social networks or even developing new social groups. All of these things are very important. The community is gaining power. It's strengthening and re-examining its values over time to decide what is really important, what can be left behind from previous years, what would they need moving forward. This whole issue ultimately is critical reflection, the community being able to sit down, look at where it's going, evaluate, and take new action. This little picture from a small kiosk of a person in Nigeria who is a member of the Village Health Worker Association that we have, and this person sort of embodies this idea that there are resources in the community. So this person is a farmer, but also he does barbing, he repairs clocks, and he repairs cell phones. So this person has a lot of resources, and the community can mobilize people like that for their own plans and actions to get things done. We have a number of tools that can be used to actually carry out some of these community change approaches. These tools have different characteristics, and we'll talk about some examples of the tools, but in the meantime what we want to do is ensure that the tools promote learning. The community learns about itself, identifies and learns about its own resources, learns about the skills it has and needs, learns new skills, new problem-solving techniques. What we also need to examine is ourselves as change agents, as facilitators, because again, we often are in that position where we want to be helpful. We can only be helpful though if we first learn from the community, listen to them, and the community accepts us. And if they do, then we can help guide the community to actually plan interventions. If they don't have a lot of experience in planning before, we can offer suggestions, but again, the planning should be theirs. But this idea of guiding or facilitating is a very important process if we're using a participatory approach, working with the community, either through locality development or social action. Okay, enabling. This is making sure the community has the skills. Many times community members actually can deliver health and health-related interventions. Much of my time in Nigeria has been spent in terms of helping communities identify, and then we train village health workers who can provide treatment for simple illnesses, provide health education to the community. And then ultimately the community needs to continue to advocate for better services. One, being able to communicate better with their local health department, with their county commissioners, with their town council, and with national organizations that can, again, carry their message farther up. So these are four of the types of things that we look for in choosing tools that can improve the community to help bring about community change. And this, again, is just looking at four different tools. Some of you may have experience with community coalitions, and that is an organization of organizations bringing together community-based organizations for a common purpose, whether the common purpose is to improve education in the community, whether it is to improve access to food. Whatever the issue happens to be, the different community-based organizations come together, and the good thing about a coalition is that they can achieve something that an individual organization cannot do on its own, because some organizations may have skills that they can contribute in terms of things like fundraising or management of funds. Another group may be very good at public speaking and communication and getting people interested. Another group may have contacts in the wider city or county that can help bring in more resources. So each group has different skills and resources they can bring to a coalition. Quality improvement teams is a concept that was actually developed by Save the Children, and the idea is that we need to set up a dialogue between community members and agency staff. We need to get both groups independently to identify what they see are the major concerns about delivering a certain kind of service, whether it's a health service, a nutrition service, a maternal health service, education, improving child reading, whatever it happens to be, bringing together community members and agency staff then to find common ground and work on locally appropriate solutions. So that's the quality improvement team. Then we have community-directed interventions where community members actually select their own volunteers, their own community health workers, who are then trained and provided with what they need. It could be health education materials. It could be, a sphygmomanometer to help take blood pressure in the community. It could be certain kind of vitamin supplements, or, as I said, in the case of Nigeria, we actually provided community volunteers with medicines because they were very far away. Many communities were far away from health centers. And finally, another approach that is a key learning approach is participatory appraisal. It could be participatory rapid assessment. It has many names. Some people may have heard of it as RAP, as not a form of singing, but a form of community analysis, where community members are brought together to identify needs, find out about their community resources, make decisions about how to improve things. And so the responsibility in this process, the facilitator encourages the community to take charge of what they want to do. So these, again, have common themes in the sense that we are first learning from the community about their needs, about their ways of life. We're not presuming to be the experts that we know everything. I mean, those approaches exist, and they have for ages, and as long as we have agencies such as health departments, there will always be some of that. Because, again, if we are looking at something like flu, we're not expecting the community to solve its own flu problem when we do have a vaccine, so it's up to the health department to organize the vaccine campaigns. But in terms of solving problems like some of the nutritional problems in the communities, everybody needs to get involved because the solutions can't be solved by an agency bringing in the right food and just donating it to everybody, because those kinds of resources and processes don't work. Many times, if something's given away free, it might even be suspected. So again, to stress the fact that in the United States these days, we are living in a multicultural society more so than ever. Again, it's been a nation of immigrants throughout, but there has been more pressure to assimilate in the past. Now there's more of a recognition that people have different unique backgrounds, and that in order to provide services for them in order to improve their food and nutrition habits. We need to understand where they're coming from. One of the things that always struck me working in Nigeria is that in the U.S., when you ask someone, what did you have for dinner, they would say beef, pork, chicken. They would name a meat. And if you ask someone what did they have for dinner in Nigeria, they would talk about whether they had cassava, yam, cornstarch, or whatever. So the center of the meal was a starch, whereas the center of the meal, was different. In the U.S., focused at that time more on meat. Now we're obviously getting away from that and looking more at vegetarian choices, but still, the idea is different cultures see food differently, and if we are going to be able to work with different groups in the community, we need to understand that and work with people in their own priorities. And these things even change over time. One of the things that struck me at the School of Public Health here at Hopkins where I work, there is a Center for Native American Health, and one of the things that became obvious is diabetes is a serious problem among the populations where they work in the southwestern U.S. And it was interesting to read articles and look at the difference in diet and how that's changed over the years. And there are still relatives of the people who live in New Mexico and Arizona, who live across the border in Mexico, who eat the traditional diet that was common 100 years ago. The three main components, the three sisters, the squash, beans, and corn. Actually, corn was a major thing in terms of making tortillas, and the diet, then was very low fat. Well, the diet now in the Southwest and the U.S. side of the border is changed. You have, instead of corn tortillas, you have fried dough, fried bread that is made of wheat and obviously has a lot more fat. And then, of course, children are being exposed more and more to the typical fast food diet, and so the change has occurred such that what we see is a greater onset of diabetes among the people who are eating either a mixed diet or they are pretty much eating a typical American diet. So the people that the Pima Indians in Mexico have the lowest onset of diabetes from the traditional diet. So knowing this kind of situation, and understanding why people have made these choices, why changes occurred, is very important in terms of sitting down with community groups and discussing with them their ability, what they can do to bring about change, to prevent diabetes if it's possible, but also to provide support and help for treatment, maintaining treatment for those who do have it. The center at school has programs through the schools, training young mothers about their own health and that of their children, working with community leaders to bring about change. So again, this is based on something, but the perception has to come from the people first before they can really internalize change. Diabetes, again, has provided an impetus for community organizing around African American churches in the U.S. There have been a number of programs. Many were organized by my colleagues back at Chapel Hill, the School of Public Health, with African American churches and recruiting like the community health worker model. They called them lay health advisors. These were members of the congregation that were chosen by their other members, so that they were respected, well known, and they would voluntarily take up the idea of tracking members who had diabetes, providing support in terms of taking the medication, but also in terms of changing and coping with their diet, because you need a lot of community and social support to make some of these changes. Food is one of those things that people are very particular about, and so it isn't, when we talked about rational, empirical, that kind of approach is not going to always work with food. You can tell people what's good for them, but what they like, the taste in their mouth, is not necessarily a rational process. It has a lot to do with values, perceptions, beliefs, long-held social norms and influence of other people, family members and friends. So this community approach where everybody's recognizing that food is a central part of your identity and your being, and of course, let alone mention basic nutrition and survival, but it has to take an approach where the community is examining its own values and figuring out for itself what is a feasible way of changing. Again, the idea of community health workers being acceptable is because they are members of the same cultural group. They're able to talk to their friends and neighbors in terms and terminology that they're familiar with. They can help control diseases that are related to nutrition and can disrupt the economic life of the community, such as diabetes. They can because they're neighbors, they can keep track of each other and make sure that people keep appointments. So these are things, because they are trusted, because they're selected by the community, because they are well known and they know their community. Organizing this type of approach is very, very helpful. Community coalitions are a way of the neighborhoods coming together, all the different community-based organizations, social groups, figuring out what can we do to solve the problem of nutritious food being available nearby. Everyone knows that you don't find many supermarkets with wide choices available in some of the poor neighborhoods of the inner city, and there actually also may be even some problems in terms of access in more remote rural areas. But here again, community groups can work with identifying the shops, working with the shopkeepers, educating them, promoting the use of these shops and the more nutritious food once they, are able to start stocking this. So the whole issue of coalitions, looking after their community and involving the shopkeepers, not just expecting an outside agency to come and teach them, but the community obviously is an important part, because if the community doesn't demand or want the new nutritious food in these shops, the project won't succeed. So the community really has to be involved. Advocacy, of course, the implication, many of you are going to be familiar with weaknesses in your own local and state laws. It may be a question of zoning, what kind of shops are available for food. It may be what kind of food is sold. Again, the decisions about selling food has to do with demand. It has to do with what's cost. It has to do with a number of things. And so any kinds of decisions about these issues need to there may need pressure put, a community social action approach for bringing about change. Even policies and regulations about the school lunch menus in your own neighborhood primary schools are very important to think about in terms of advocacy. So it's not, and again, there may be advocacy needed for corporations that are involved in producing food or involved in setting up shops and supermarkets. And then, of course, these local coalitions and groups can look toward national partnership and look at Congress, look at even the administration, because it's one thing for Congress to pass a law, it's another thing for the written guidance to come from the Department of Agriculture, Department of Health, Human Services. They translate the law into guidelines, and so again, advocates must be active at all levels. And again, this can bubble up from the community and their representatives in larger national associations. So again, just coming back to our notion of being aware of the communities in our town, in our city, in our counties, and that we are many in one. Here's a picture of the Ukrainian Orthodox Church in a section of Baltimore that historically was a Polish and Ukrainian neighborhood, but now we have immigrant populations and new neighborhoods and people from Somalia, Laos, other Latin American countries that are new to the area. They still speak their language. They still have their local food beliefs and customs. And if we're going to work with them on improving diet given what's available in their area, we really need to start where they are and find out how they perceive the situation, what resources they have. And also, not only are there different food customs and experiences, but there are different experiences with community action. In some countries where they have come from, one can be arrested or shot if you protest or take community action. So there may be reluctance in a new environment to get actively involved. And so we have to work with people from the situation that they come from, understand how they organize, understand their own forms of leadership, the elders in their community, etc. And again, the first step is learning from the community how it functions and how it sees problems. So in terms of working for community change, my recommendation is taking a normative re-education approach that can include locality development, that can include local community volunteers, that could include coalitions, that can include rapid assessment, participatory assessment, where the community diagnoses its own problems. So again, the approach that I'm concerned about for bringing about community change is that the community needs to direct its own change, let the community teach us what they need, what they know, and we can build on that. We can strengthen their capacity to achieve their desires. Thank you very much.
Dr. Brieger, thank you so much. And to help summarize for our audience, what are a few questions that you think community leaders should ask themselves when they're starting to address a problem like food security or addressing diet-related disease? Based on your models, what are some questions people should be asking, just to sum up?
I think one thing that's very important, of course, is that they need to find out and be sure that they know all the different community-based organizations that are operating, and whether they're groups that are focused on women or religious groups or economic associations, groups for teenagers, making sure that they have asked around and know all the different groups that might be interested, and be sure that they're represented and brought on board. Sometimes we find that teenagers or even children's groups are very important because when you're talking about very young child nutrition, it's oftentimes the older siblings that are responsible, or maybe grandparents. Sometimes grandparents are more active in community associations than parents who are busy working. So this is an important thing, sort of diagnosing or finding out the different groups that are active in the community that can get on board. That's one of the first steps. The second, again, is this issue of perceptions of food, what people like, what they don't like, why they like it. Are there different one thing I was seeing on television the other day is that parents who feed their children child-friendly foods really are doing a disservice, because those kinds of foods are oftentimes higher in fat and salt and sugar, so that it's better to focus on an adult diet. So again, it's important to see what people's perceptions. If parents think, oh, I'll only be able to feed my child mac and cheese, they won't eat anything else, and that's not right. But the point is that may be a belief parents have. Again, like I said, finding out more about the food choices and beliefs of communities that have come from other countries, what they see. I mean, there are beliefs about foods having not just nutritional but medicinal value. Some foods do or do not go together. There are certain taboos about what kind of foods people can eat. People coming from settings may have beliefs about pregnant women should not eat certain things that we would think would be nutritious, but are taboo for one reason or another. So the issue of asking questions, who is out there, who are the community groups that are influential and represent the key people that are affected by these, and what do people believe? Because just because you're a quote typical American community, white, middle class, whatever, doesn't mean you don't have beliefs. I was talking to a group of students the other day about some of the tropical diseases that I had worked with and some of the beliefs people had. And I cautioned them, before you call any of the beliefs bizarre or strange, think about things like beliefs in this country about something called heartburn. It's really hard to classify that as a medical condition. People take all kinds of medicines and eat foods they shouldn't, and then take a medicine and this and that. So here is a cultural condition that is very odd, very strange, and even in the U.S. So I think that's another thing. We should be open to the fact that we all have various kinds of interesting beliefs that may affect our nutrition and diet.
Wonderful. Thank you again for your presentation. And Dr. William Brieger is a professor at the Johns Hopkins School of Public Health. And thank you again. We'll be sharing your slides so people can see them later. We appreciate your time. Thank you.
Thank you.